It really is pretty remarkable, isn't it? When you think back, for people needing long-term hemodialysis, just keeping their access working was a huge hurdle.
Oh, absolutely.
And now, patients are living so much longer, healthier lives on dialysis, which is fantastic, obviously.
It really is. But that success brings its own set of challenges, doesn't it? Especially keeping that arteriovenous, the AV access going long term.
Exactly. Because those initial sort of standard options in the arms, they eventually just wear out or aren't suitable anymore for some patients.
Right. You get to a point where the usual fistulas, the grafts, and the upper limbs, they're just not on the table anymore.
Okay, so that's what we're going to tackle in this deep dive, this really complex area. What do you do when those standard options are exhausted? We're exploring the advanced world of complex hemodialysis access procedures.
The techniques surgeons turn to when the usual spots just won't work.
And we've got a really solid source for this. We're drawing from chapters in Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition.
Yeah, that's basically the Bible for vascular surgeons. So the information is top-notch, really coming from the experts.
So our mission today is to get a handle on this surprisingly wide range of complex AV options. What are the pros and cons, and what goes into a surgeon's decision-making process here?
And it's important context, I think. While these complex procedures, yes, they do carry higher risks than your standard arm access.
Right.
They're generally still seen as better than just leaving someone with a long-term catheter.
Because catheters have their own problems.
Big time. Infection is a major one, and also central venous stenosis, that's narrowing or blockage in those big veins heading back to the heart. That can make dialysis really difficult or even impossible through that route eventually.
Okay, so the standard access isn't working. What are the sort of first principles surgeons follow when they start thinking about these more complex REDs?
First thing, absolutely critical, is getting a really detailed history of all the previous accesses.
Everything they've had before.
Everything. What type was it? And crucially, why did it fail? Was it clotting?
Yeah.
Infection? Did it narrow down? Stenosis? You have to understand the failure modes.
Yeah, that makes sense. You don't want to just repeat something that's already failed for a known reason.
Exactly. So after the history, what's next?
Then it's all about mapping out the patient's remaining blood vessels. A really careful look at the vascular anatomy.
Just because one access failed doesn't mean everything in that area is unusable.
Right. And this often means going beyond just ultrasound, I gather.
Often, yes. You frequently need contrast angiography, that's for the arteries, and venography for the veins, using dye and x-rays to get a really detailed picture, a roadmap, essentially.
Like a proper vascular investigation. Okay. Yeah. And even with that map, there's a big push to use up all the upper arm options first, isn't there?
Oh, definitely. The textbook really stresses this. Even if someone's had multiple failures, a good venogram might show there's still a usable vein hiding in there, maybe a paired brachial vein, or the cephalic vein is still open. And sometimes you can treat problems like central venous stenosis first.
Yeah.
With angioplasty to widen the vein, maybe put in a stent, or use special devices like the hero graft or an inside-out technique. We'll probably touch on those later.
So you really try to salvage the upper limb, if at all possible.
Always the goal. Least invasive, most established options first.
It sounds like creating a strict step-by-step guide and algorithm for complex access would be pretty tough.
That's a really good point. It is tough.
Why is that?
Mainly because there just isn't a huge amount of high-quality, evidence-based research comparing all these different complex procedures head-to-head. They're less common by definition, and every patient is so different, their anatomy, their history. So while there are general guidelines, it really comes down to the surgeon's experience and judgment, tailored specifically to that patient.
Right, individualized medicine. Okay, let's start exploring some specifics then. The book kicks off with autogenous access using the patient's own veins. Yeah.
Exactly. And there are broadly two types here. Translocation, where you completely detach a vein and move it somewhere else.
Okay.
And transposition, where you mobilize the vein but leave one end still attached where it originally was.
Got it. Let's start with translocation. One mentioned is a brachial artery to axillary vein fistula, but using a vein brought up from the leg, the saphenous or even the femoropopliteal vein. That sounds like major surgery.
It is a bigger operation, for sure. It's positioned as an alternative to just going straight to the thigh for access, especially if the upper arm veins are gone. But maybe a standard upper arm fistula isn't ideal. You're basically borrowing a leg vein to build an access in the arm.
Interesting. And what about saphenous vein forearm translocation, bringing the leg vein to the forearm?
Yeah, that's another one. The saphenous vein from the leg is moved to the forearm, often set up as a loop or maybe a straight connection. But the thing that really jumps out here is the huge variation in how well these last. Yeah, reported secondary patency rates, meaning how long it stays open, with some help from interventions, they range from like 50% up to 96% at 1 year in different studies.
Wow, 50 to 96%. That's a massive difference. What causes that variability?
It's likely a mix of things. The quality of the saphenous vein itself can vary a lot between patients. Surgical technique plays a big role, of course. And the patient's overall health, other vascular issues. It just highlights that these less common procedures can be a bit unpredictable sometimes.
Okay. Then there's the femoropopliteal vein arm translocation, also using a leg vein in the arm. What's the story there?
Well, one key study by Huber and colleagues showed pretty good patency. It stayed open well. They reported 67% primary and actually 100% secondary patency at 18 months.
That sounds great.
It does, but you have to balance that against the higher complication rates they saw. Things like wound hematomas, compartment syndrome, that's dangerous pressure buildup in the muscles, and even Steele syndrome in the arm, where the access pulls too much blood away from the hand.
Right, that risk of Steele when using a big leg vein in the arm seems like a recurring theme. The book also mentions something called AKI-IV arm composite, autogenous vascular access. Sounds fancy.
It's quite an ingenious idea, actually. ATKV uses both the great saphenous vein and the femoral vein from the leg.
Both. Why?
The thinking is, by combining pieces of these two veins in a specific way, you can create a smaller diameter where it connects to the artery. The hope is that this reduces the risk of that Steele syndrome, the hand ischemia.
Ah, clever, like flow engineering.
Kind of, yeah. One study found an 81% secondary patency at a year, and importantly, only one case of Steele. So it's an innovative way to try and tackle that specific complication.
Okay, interesting. Let's switch gears to transposition now, where the vein stays attached at one end. First one is brachial vein transposition.
Right, so here you're using the brachial vein, one of the deep veins in the upper arm. You carefully free it up, keeping it connected at one end, and then swing the other end over to connect it to an artery nearby, like the radial or the brachial artery itself.
And how does that work out?
Early reports were pretty positive. Secondary patency rates do vary in the literature, but some studies show really good results, up to 92% at 1 year. Interestingly, the recommendation is often to do this in 2 stages.
2 stages. Why split it up?
The idea is stage 1, you make the artery to vein connection, then you wait maybe 4 to 6 weeks. This gives the vein wall time to thicken up a bit, get used to the higher arterial pressure, they call it arterialization. Then in stage 2, you go back in, carefully mobilize the now slightly tougher vein, being super careful around the nerves, and tunnel it so it lies just under the skin, making it easy to stick needles in for dialysis.
Makes sense. Let the vein mature a bit first.
Yeah.
Okay, next is saphenous vein transposition. Similar idea, but using the leg vein again.
Exactly. But unlike translocation, here the saphenous vein stays attached up in the groin at the saphenofemoral junction. You mobilize it down towards the knee, then tunnel it up as a loop in the thigh, and connect that loop to the superficial femoral artery.
Any key things to know about this one?
Yeah, the book points out you really need a decent-sized vein, over 3 millimeter diameter, and you have to wait to use it delay cannulation for at least 6 weeks to let things heal and reduce bleeding risk. It also notes it might not be great for patients who are morbidly obese if they have a large panorrhea, that flap of abdominal tissue, which could get in the way.
Right, practical considerations. And then femoral vein transposition. Using the big femoral vein in the thigh itself, that sounds potentially risky given the location.
You're right to flag that. Dr. Gradman's group has the most experience with this, and initially they saw a worrying amount of limb ischemia, the access stealing blood flow from the leg itself.
Oof.
Yeah, but they refined their technique over time, making the connection point smaller, being really picky about which patients were suitable candidates. They even did prophylactic fasciotomy sometimes, releasing pressure in the leg muscles preemptively.
So they learned how to mitigate the risks.
They did. Other studies show similar patency, but yeah, the potential for ischemia, venous hypertension causing leg swelling, even high-output heart failure in some patients. It means you need very careful patient selection and real surgical skill.
The technique sounds meticulous.
I'm here.
Careful dissection, tunneling, even tapering the vein end for the connection.
Yeah.
And there was mention of a composite vein graft for higher-risk patients.
Yes, exactly. If the patient's vein isn't quite long enough, or maybe to create a better size match for the artery connection, you can actually sew a piece of prosthetic graft, like PTFE, onto the end of the patient's femoral vein. It helps bridge the gap or optimize the setup.
Okay. And lastly, for autogenous, ankle fistulas. Sounds like scraping the barrel.
It really is quite rare, mostly just case reports out there. Connecting an artery like the posterior tibial or dorsalis pedis to the saphenous vein down at the ankle. You absolutely need detailed pre-op checks, toe pressures, angiograms, and it's a definite no-go if the vessels are badly calcified or there's no pulse in the foot. Honestly, because there's so little data, how well they actually work long-term is pretty unclear.
Okay, so that covers using the patient's own veins. Let's move to prosthetic access using synthetic grafts. First up, chest wall and neck access. Where do these typically go?
Several common spots. You might see a loop graft connecting the axillary artery and vein on the same side of the chest, or a straight graft going from the axillary artery across to the other side, connecting to the axillary or jugular vein. That's the necklace access you sometimes hear about.
Necklace access, right?
Or even a straight graft from the brachial artery up to the jugular vein in the neck. Initially, we didn't have much outcome data beyond small reports, but that's improving.
That necklace configuration seems like it could be tricky for sticking needles in, or if something goes wrong.
It can pose challenges. While some early studies looked good, a bigger, longer-term study found secondary patency dropped to around 54% by 4 years. And if it clots, yeah, because the connections are far apart, fixing it might mean extra incisions near both ends to really clean it out.
Makes sense. What about the brachial to jugular option? When would that be useful?
Patency seems pretty similar to the axillary loop grafts, based on work by Vega and others. It's particularly handy if the patient's subclavian vein, that big one under the collarbone, is blocked, but the other central veins are still open. The book also mentions a neat trick called an internal jugular turndown for specific blockage situations, basically rerouting the jugular vein to create an outflow path.
Interesting surgical solutions. The same side, ipsilateral axillary loop on the chest wall, that seems like it might preserve options on the other side.
That's a key advantage, definitely. You keep the other side completely untouched for the future. Lakety's group showed good secondary patency with this. Plus, having the venous side of the loop positioned laterally on the chest makes it easier to do interventions like angioplasty if it narrows.
Any downsides? Steele syndrome.
Interestingly, major studies haven't really reported much access-related Steele with this type, even in patients with previous hand blood flow issues. And it might have a lower infection risk than thigh grafts, which could make it a good choice for some obese patients. Though, if it does get infected near the axillary vessels, controlling that infection can be very challenging surgically.
The surgery itself sounds complex, working around the collarbone and chest muscles.
It is intricate. You absolutely need that venogram first to confirm the central veins are wide open. Positioning the patient, tunneling the graft correctly, especially considering breast tissue, it all requires careful planning.
Okay. Now, there's a specific device mentioned, the hero graft. Hemodialysis, reliable outflow. This is for a very particular problem, right?
Exactly. The Hero is designed specifically for patients with bad central venous stenosis or blockage that stops them from having a normal upper arm access. It's a hybrid system.
Hybrid? How so?
It has two main parts. One is a standard-ish graft connected to an artery in the arm. The other is a special venous outflow catheter component made of silicone that gets threaded all the way into a central vein, usually right down to the right atrium of the heart.
Ah, bypassing the blockage.
Precisely. The two parts are then connected by a titanium piece under the skin near the shoulder. It's FDA approved specifically for these catheter-dependent patients with central vein obstructions.
And how well does it work? What are the outcomes?
The results are, well, they're mixed. Initial studies showed, primary patency, better secondary patency. A big meta-analysis found maybe lower primary rates around 22%, but secondary patency around 59% at 1 year. There's a notable risk of Steele syndrome with hero grafts too, about 6%. There's also a newer thing called the superhero adapter, which lets you connect it to special early cannulation grafts, meaning you might be able to use it for dialysis almost immediately, skipping the need for a temporary catheter.
Right. Okay. Moving down the body now. Prosthetic grafts in the lower extremity, the thigh. This seems like the go-to after upper arm options are gone for many people.
It often is. The surgery can be relatively simpler than chest wall stuff. Patency rates are often comparable, sometimes even better than upper arm prosthetic grafts. Complications might be easier to manage than chest wall ones. And a big plus for patients, both hands are free during dialysis.
But there are downsides too.
Definitely. The big ones are a significantly higher risk of infection compared to arm grafts and an increased risk of ischemia, cutting off blood supply to the leg or foot.
And does it matter where in the thigh the graft is placed? Like higher up versus mid-thigh?
The data suggests patency rates are pretty similar between upper thigh loops and mid-thigh loops. Infection is the main worry in the thigh. Rates can be quite high, anywhere from 8% up to over 40% in some series. Limb loss is thankfully low, maybe 1–3%, but ischemia does happen.
Any specific configurations?
Obese patients with grafts crossing from one femoral artery to the other vein, those tend to need more interventions. The mid-thigh loop, described by Scott and colleagues, tries to reduce infection risk by avoiding the groin crease and any overlying penisis. Plus, it saves the proximal femoral vessels for later, potentially. Crossover grafts have higher infection risk because you need incisions in both groins.
Makes sense. And the technique involves checking the vessels carefully beforehand.
Absolutely. Pre-op duplex ultrasound is key, sometimes angiography too, to check for vessel patency, any calcium buildup. For a proximal loop, it's usually a groin incision, using the superficial femoral artery for inflow. A 6mm graft is common, trying to limit ischemia risk. For the mid-thigh loop, the incision is more medial, along the sartorius muscle, and the graft is tunneled more laterally.
Okay. Now, a different material entirely. Cryopreserved vein allografts. Veins from deceased donors.
Yeah, cadaveric veins that are specially preserved. Their exact role is still evolving, but they can be an option, especially for reconstructing an existing access that's failing, or maybe in patients with active infection.
Infections. Why there?
The thought is the allograft tissue might handle infection better in some situations. One study showed decent secondary patency, around 66% at a year, but there are real risks. The allograft itself can get infected later or even rupture, which can be catastrophic limb loss, even death. So they're used very selectively.
Definitely sounds like a specialized option. Okay, finally, the book gets into really unconventional procedures. When even the upper and lower limbs are completely out of options, these sound like true last resorts.
They really are, often just a documented in case report, so we don't have great long-term data on durability or complications, but they can be life-saving when there's literally nowhere else to go.
Like what kind of things?
Things like creating access directly on the chest or abdomen, surgically connecting to the big central veins, sometimes bypasses to the heart's right atrium, or connecting an artery like the femoral or axillary to the vena cava or even the renal vein. People have tried external iliac artery to iliac vein grafts on the abdominal wall, too. Axillary artery straight to the right atrium for severe central vein thrombosis. Really complex stuff.
Wow. Just incredible ingenuity required. It also mentions arterial access.
Yeah.
Connecting artery to artery.
Yes, that's another unconventional approach, usually considered if someone has really bad Steele syndrome from other accesses or high output heart failure, because these AA accesses tend to have lower blood flow rates.
How do they work?
Various ways. A loop between parts of the axillary artery or the brachial artery. The brachial A loop might cause less ischemia and can sometimes be done under local anesthetic. But big downsides. You can't infuse meds through them during dialysis, and you need really prolonged pressure afterwards to stop bleeding from the artery puncture sites. Some have even transposed the superficial femoral artery or created loops between superficial and deep femoral arteries.
So lower flow, but maybe avoids other complications. And even for placing temporary dialysis catheters, when the usual spots like the neck veins are blocked, there are fallback options.
There are, again, last resorts usually, things like transthoracic SVC catheters literally puncturing through the chest wall into the superior vena cava, or the inside-out technique where you go up from the leg vein, poke a wire out through the blocked neck vein, and pull a catheter through that way. Then there are translumbar IVC catheters going through the back into the inferior vena cava, and even transhepatic catheters going through the liver to reach the IVC. These all have their own significant risks: clotting, infection, bleeding, the catheter moving. The transhepatic route especially is very high risk, really only for desperate situations.
Truly the end-of-the-line options. Finally, the book briefly covers pediatric access. Obviously, kids present unique challenges.
Huge challenges. For kids with kidney failure, transplant and peritoneal dialysis are strongly preferred. Hemodialysis is often just a bridge or last resort. There's less experience, less published data, especially for very young children.
What are the key considerations?
KDOQI guidelines suggest PD or catheters for kids under 20 kilograms. But catheters carry risks too, including causing central vein stenosis, which is even more devastating in a child with limited future options. There's sadly a trend of more access infections in younger kids, maybe linked to longer transplant wait times. The absolute priority is preserving future access sites.
So if they need long-term hemodialysis.
The autogenous AV access, using their own veins, is still the best and possible. Outcomes can be good, but failure to mature is common. Microsurgical techniques are essential magnification, tiny sutures. Prosthetic grafts are an option if autogenous isn't feasible. Even complex procedures like femoral vein transposition have been used successively in selected kids. It requires very specialized pediatric surgical expertise.
Wow, that is an incredible tour through the complexity of AV access when things get difficult. It really drives home the sheer ingenuity and adaptability required here.
It really does. And it underscores that choosing the right procedure isn't simple at all. It's deeply individualized. You have to weigh the patient's history, their specific anatomy, their other health problems, and critically, the surgeon's own experience with these demanding techniques.
And it's crucial to remember, like you said at the start, while these complex options do have higher risks than standard access, they are often absolutely vital. Vital for quality of life, even for survival, for these long-term dialysis patients, and generally much preferred over being stuck with a chronic catheter indefinitely.
Absolutely. Which kind of leads to a final thought, maybe for you listening. When you see this incredible range of advanced techniques surgeons have developed, what's next? What further innovations could possibly emerge to make life even better for dialysis patients facing these really tough access challenges? It's always this balance, isn't it, between surgical complexity, risk, and ultimately the patient's outcome and quality of life. Something to ponder.